Hello, good evening, everybody. Welcome to this webinar on Carbetocin in Action, case studies from labor room, from Heathrow. Heathrow Healthcare, as you all know, we have 25 years of excellence with 36 state-of-art manufacturing facilities. We have 300 plus products in portfolio and our presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. We have Asia's largest manufacturing facility at Visakhapatnam, Andhra Pradesh. Heathrow Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wider product range encompassing multiple specialties. Pioneering in quality and innovation, we have distinction of bringing 4 biosimilar products to market within 5 years of launch. Today's webinar, Carbetocin in Action. Doctors will agree with me that PPH is a condition which is potentially very dangerous and could be a disaster. Carbetocin is used in the management of PPH, and there are many studies documenting the use of PPH. But you will always like to have our own doctors, their insights on use of Carbetocin, their insights on PPH management. For this today, we have got Dr. Lakshmi Swetha Karlapudi is expert to give her insights into PPH management with Carbetocin. Madam is MBBS DNB Obstetric Gynecology, Clinical Head Obstetric and Gynec Department, Sanjeevani Hospital, Pune, Gold Medalist MBBS. Madam, that's really great. Cosmetic gynecologist, infertility specialist, and of course, congratulations, Mrs. Maharashtra 2024 winner. With this, I hand over the session to Dr. Lakshmi for her insights on PPH with Carbetocin.
Thank you so much, sir, for the kind words. And without any delay, we'll go into the topic. So today we are going to discuss how PPH is important and how can we tackle it with the help of Carbetocin. So as a clinician, we all know that the most dreaded complication for any woman during the pregnancy is at the time of delivery, she can have hemorrhage, like uncontrolled bleeding. So that the same thing we call it as postpartum hemorrhage. So according to the definition, we say postpartum hemorrhage is loss of at least 500 ml of blood following a normal vaginal delivery or 1 liter of blood following a cesarean section. So PPH can occur in any woman who is even not at risk. So this we see in our day-to-day practice, because in those patients who we already expect and we think about that this lady is going to have PPH, and we take precautions like giving them preoperative medication care, everything, keeping blood ready, and all those patients who want to bleed much. But in other case, in the woman in whom we do not expect that she goes into PPH, suddenly, surprisingly, this woman can land up in PPH. So this PPH is the leading cause of maternal mortality and the primary cause of nearly 1/4 of all maternal deaths. So we do not wait for a half liter or 1 liter blood loss to happen. So the time when we notice that this lady is having more bleeding after the delivery, we have to start acting, initially giving medication and many surgical ways to tackle this postpartum hemorrhage. So postpartum hemorrhage, it is unfortunate, but yet it is common. So see, maternal mortality, which is a leading cause, है ना? This PPH is a leading cause of maternal mortality, which accounts for about 35% of all the maternal deaths. So this maternal mortality rate was 240 per 1 lakh live births compared to only 16 in developed countries. So the difference is huge. So we, being still a developing country, all the clinicians should have a proper thought about postpartum hemorrhage, should get proper training, and they should not panic when the patient goes into PPH, and they should have all the arms with them, like medications which can control this postpartum hemorrhage and can save the life of the patient finally. So the global incidence of PPH is 14 million women suffer from postpartum hemorrhage. The incidence of postpartum hemorrhage reported is 2% to 4% after vaginal delivery and 6% after the cesarean section. Because nowadays, the number of cesarean sections are increasing in number. So the rate of postpartum hemorrhage is also gonna go high. So in India, the incidence of postpartum hemorrhage is 38% of maternal deaths are due to postpartum hemorrhage and 25% of the total global deaths take place in India. See, 1/4 of the deaths due to postpartum hemorrhage is happening in our country, and 2/3 of these are attributed to postpartum hemorrhage. India has an unexceptionally high maternal mortality rate of 540 per 1 lakh live births. So, coming to the causes of postpartum hemorrhage. During our undergraduation and post graduation, we all know this, and this is a favorite question during our exams also. What are the causes of postpartum hemorrhage? So, why it is important for us to know the etiology of postpartum hemorrhage? Because once we know the cause, we can assess the risk of the patient, that which patient can go into this postpartum hemorrhage. We can take preventive measures and we can protect the woman, right? So the 4 T's are the tone, thrombin, trauma, and tissue. Coming to the tone, so when the uterus, after the delivery of the baby, when it fails to contract, when it fails to come back to its normal position, like the muscle, if it fails to contract, the sinuses are open. So they bleed torrentially. So the blood loss is more. So there are again multiple reasons why this tone is affected. In that, the most common reason is multiparity, especially in countries which are developing. People usually go for 3, 4, 5, 6 deliveries, right? So the uterus loses its tone and it fails to come back to its normal tone. So when the uterus fails to contract, because of that reason, this lack of tone is one of the most important reasons of postpartum hemorrhage. Overstretchability of the uterus. So if the baby is big, if the liquor is more, big baby, polyhydramnios, twin pregnancy. So all these are the reasons again where the uterus will lose its tone because the muscle is overstretched. So it fails to come back to its normal position. Again, when the tone is lost, so if the oxytocin usage is like if they didn't use a prolonged labor, if oxytocin is used for long duration, the uterine muscle got fatigued. It is contracting, relaxing, whole 24 hours, 36 hours of labor. So the uterine muscle is already fatigued. There is no proper amount of glucose, ATP, which will help the muscle to contract. So post delivery, this kind of uterus, which has undergone prolonged labor, also fails to contract. So these are the most common reasons that we face during our practice, in which we have to expect that this patient is going to have tone issues. Now coming to the thrombin. So in those patients in whom there are coagulopathies, like they have clotting issues. But now today, these days, because we see most of IVF pregnancies, high risk pregnancies, elderly preemies, so during pregnancy itself, prophylactically, to prevent hypertension, to prevent intrauterine growth restriction, we obstetricians, we are giving ecosprin, heparin, all these things to give the live birth rate, positive live birth rate to the patient, to not to have any complications during the pregnancy. So all these antiplatelet drugs or anticoagulants, they are going to cause postpartum hemorrhage after the delivery. So this is where the blood clotting issues will happen. So now coming to the trauma, this usually happens after a normal vaginal delivery where there is a cervical tear. Or a trauma can also happen in a lady who had scar over the uterus, goes into the labor when there is scar rupture also. So where there is uterine trauma also, this can cause postpartum hemorrhage. And then the tissue, sometimes because of retention of placenta, clots or membranes, so because of these tissues remaining inside, the uterus starts bleeding. So this can cause primary or secondary postpartum hemorrhage also. So these are the 4 important causes of postpartum hemorrhage. Next slide. So how do we diagnose this PPH? Usually when the moment we see that this lady is bleeding more than normal, our mind should work so fast that we have to advise our staff, we have to call for help, the other doctors in our hospital to help this lady give all the medications and supportive care. So the other important things that we can see is abdominal tenderness. So, and circulatory collapse can happen when there is more blood loss. when the patient is unable to control, like compensatory shock hota hai initially, and then decompensatory shock, then the patient goes into the collapse. So increasing abdominal girth, loss of uterine contractions, maternal tachycardia, vaginal bleeding. So these are all the common clinical findings of postpartum hemorrhage. But mostly after the delivery, even before the placenta is delivered, some patients will start bleeding. And sometimes after the placenta is delivered, some patients starts bleeding. So bleeding is the first most important sign of postpartum hemorrhage before all these symptoms will arise. So once you see the bleeding, you have to start acting. You have to give the proper medications to treat this postpartum hemorrhage. So these are the degrees of shock. But usually we don't want all these things to happen, moderate and severe shock. So then the blood clotting issues, and the patient will go into so DIC, all these things will happen. But most of the times now, because of all these medicines and all, PPH is mostly cured. So if the blood loss is 500 ml to 1 liter, that is she loses about 10 to 15% of her blood. So then the blood pressure will be normal, it is maintained, so the patient can compensate. So the symptoms she will be having is tachycardia, dizziness, and palpitations. In mild PPH, the blood pressure can slightly fall. The same thing, she can have tachycardia, moderate if the blood loss is more than 1.5 liter. So there is marked fall in the blood pressure. The patient feels restless. Pallor will be there. In the case of severe PPH, almost more than 2 to 3 liters of blood loss. So then the patient goes into the collapse. So diagnosing this postpartum hemorrhage. So initially, once we see the patient that she is bleeding, we'll understand that she is in postpartum hemorrhage. So rapidly we have to assess. We have to keep a pulse oximeter. Even for a normal delivery or anyway C-section patient will be under the monitoring only. So we can see that because of the blood loss, the pulse rate will become more, and she can start having hypotension. There will be tachycardia and hypotension, not hypertension. So you have to keep on monitoring her vitals, and you have to keep on checking the amount of blood loss. So assessment of entire genital tract. So once you see that this patient is having postpartum hemorrhage, now this is the time where you have to know the reason for postpartum hemorrhage. If it is the tone, you have to give uterine tonics. If it is the trauma, like if there is any laceration or a tear trauma, then you have to give stitches. You have to repair the trauma. Or if there is any problem, like some retained products are there, placenta is there, membranes are there, you have to remove them. So manual examination you have to do. You have to see for any lacerations. And if possible, if the reason, manually you have examined the patient and you can't find the reason, if you could have a blood side ultrasound, it is always better to see for any retained products inside. So one of the important reasons, another important reasons is uterine inversion, where the uterus will get inverted while the placenta is coming out. In such condition, also the patient goes into the shock and she goes into this postpartum hemorrhage. So the laboratory investigations, the same time, all these things should go hand in hand. So that's why when there is postpartum hemorrhage, it is always important to uh, to have another doctor or doctors, your nursing staff, anybody who is there in the hospital should always, everyone should be there with that lady and with the doctor who is treating her, because one will be assessing, one will be monitoring, one will help you do the catheter, and one will help you give the medication, and the other one will help you collect the blood to send it for blood count, and the other doctor will call the lab to like issue the blood and blood products. So it is all a teamwork. So how the approach should be towards postpartum hemorrhage. So if there is a poor uterine tone, or once you examine, you cannot find the contracted uterus. So uterus feels relaxed, boggy, and soft. It may be felt above the level of umbilicus because it is big, it didn't contract yet. And it is filled with blood and the clots. So what you do? Usually we don't do ultrasound. So we usually, what we do at this time is we have to give uterotonics and send the patient's blood for blood count, coagulation profile, renal and kidney function test, and electrolytes. And the management is we give uterotonics like oxytocin, prostaglandins, prostadine carboprost, and mithyrgine ergot alkaloids. So, and then if the uterus still didn't get the tone, uterine balloon tamponade is a very promising maneuver which will help this kind of uterus to stop the bleeding. So, so then if there is any trauma, so first assess and locate where the trauma is. Most commonly, the cervical tears happen after normal vaginal delivery. So with the help of that clockwise manner, with the help of sponge holding forceps, we have to trace the whole cervix with the help of the assistant under good vision. So if we see where the tear is there, it is always better to repair the tear. So in trauma, if we repair the trauma, then the postpartum hemorrhage is tackled. If there are any extragenital causes like such as subcapsular liver rupture, sometimes fundal pressure dete hai na to deliver the baby. In such condition, patient have liver rupture, rupture of ovarian or splenic vessels. In such conditions, if you don't find any bleeding, but all these are concealed hemorrhages, right? If you see that the patient is collapsing and you can't find any trauma anywhere, it is better to take the help of a radiologist imaging to find these causes. So inspection during C-section and ultrasound can help you. So the management is repair of identified genital trauma and may be required in cases of broad ligament or supralevator hematoma. We can go for pelvic arterial embolization, which is very rare. So the retained products. Again, during the retained products, you can so after normal vaginal delivery, if the placenta fails to get delivered, and sometimes in very rare condition, it happens that the internal os closes. It is difficult for the hand to go inside. In such conditions, it is always to examine under anesthesia. And then manual removal of placenta is advised. After manual removal of placenta, also again the uterus can get into atony. In such conditions, again the management is usage of uterotonic agents. And coagulopathy, we all know. So if the reason is coagulopathy, then it is always better to give blood and blood products to the patient, which will help to prevent or to treat this postpartum hemorrhage. Next slide. So rationale for the development of carbetocin in new heat stable form. Carbetocin, the importance or the advantage of carbetocin is that it is stable even at room temperature and it is a convenient vial preparation. Oxytocin and ergot alkaloids should be kept in a refrigerator to avoid degradation because oxytocin works well when it is kept at under the temperature of 2 to 4 degrees centigrade, right? So this heat stable formulation of oxytocin is currently not available. Previous formulations of carbetocin initially when they were manufactured, they were also heat labile that they should be stored under temperature of 2 to 8 degrees centigrade. So in those areas where the resources are not available, like refrigeration, cold chain, if these are not available, these medicines won't work. So the advantage of the newly available carbetocin is that it is stable at room temperature. It has got a shelf life of 24 months at 30 degrees and 75% of humidity. So in all the developing countries, so this carbetocin is like a boon. It doesn't need any cold chain and it is provided in a vial form. Next slide. So use of uterotonic agents. So the time of administration. We all know the prophylaxis of third stage of labor, right? Active management of third stage of labor. So this active management of third stage of labor, this is being introduced by WHO. And this training is given to all the ladies, like all the doctors who are obstetricians, and those in underdeveloped countries, those who deliver the babies. So this oxytocin or any uterotonic agent, it has to be given after the delivery of anterior shoulder. And it can also be given at the end of second stage of labor following the delivery of placenta. So all these things can be done, but usually oxytocin, preferably it is to be given after the delivery of anterior shoulder of the baby. Prophylactically, we can use all these things for the prevention of postpartum hemorrhage and active management of third stage of labor. So there are 3 steps For the active management of third stage of labor, every obstetrician or a lady who is delivering gives these kind of services should know. In the active management of third stage of labor, one is giving oxytocin intramuscularly 5 to 10 units after delivery of anterior shoulder. The second step is controlled contraction. The third step is giving suprapubic pressure. So all these things, if they are followed properly, they have have the evidence that following this active management of third stage of labor prevented 90% of postpartum hemorrhage. So this is the best thing that any doctor can do to save their lives and patients' lives. So the therapeutic uses, like we can use this for a once the lady goes into postpartum hemorrhage also, first we give all these uterotonic agents. So the uterotonic agents that are available today are oxytocin, carbetocin, ergometrin, mesoprost, carboprost, all these things. So carbetocin is a next generation drug for the postpartum hemorrhage. It is synthetic and it is long acting. Carbetocin was created by making several modifications to the original oxytocin structure. Why these modifications are made? To make it heat stable and to help it have long duration of action and long shelf life. So because of these changes, the enzymatic degradation is reduced in the body. So that is the reason why it is having prolonged duration of action. So it is an analog of oxytocin, but it is heat stable and it is long acting. So the indications are prevention and treatment of postpartum hemorrhage. One vial contains 100 micrograms of carbetocin in 1 ml. One vial contains 1 ml solution that is containing 100 micrograms of this carbetocin drug. So now the clinical evidence. Carbetocin is non-inferior to oxytocin. We all know that. So because the action is similar to oxytocin, there is a largest clinical trial, the Champion trial, where the carbetocin hemorrhage prevention trial. The studies show that they have compared the effectiveness of oxytocin with the carbetocin in the prevention of postpartum hemorrhage after vaginal birth. So they have studied almost 30,000 women across 10 countries. The primary outcome is that the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents and around 1000 ml of blood. Next slide. So in this study, the frequency of blood loss, at least 500 ml or the use of additional uterotonic agents with carbetocin was proven to be non-inferior to oxytocin. So what is the conclusion of this study is that carbetocin was not inferior to oxytocin, either in controlling the blood loss or if they have used only carbetocin also, the requirement for the usage of additional uterotonic agent has reduced. So it is equally efficacious to oxytocin. So the additional, as I have told you, the use of additional uterotonic agents and interventions to stop the bleeding and adverse effects did not differ significantly between these two groups. So carbetocin for prevention of postpartum hemorrhage, the Cochrane review. In this review, they have took data from 11 studies involving 2,635 women. So the conclusion again is that for women who undergo C-section, carbetocin resulted in statistically significant reduction in the need of other therapeutic uterotonics compared to the oxytocin. Also, carbetocin is associated with less blood loss compared to the syndrometrin in the prevention of postpartum hemorrhage for women who have vaginal delivery and is associated with significantly fewer side effects, right? So if you use Mithergin or the other prostaglandin F2 alpha, the carboprost and all, patients will have side effects, right? So patient can be having nausea, vomitings, like loose motions can happen if we give mesoprost, can have fever after the usage of these medicines. And Mithergin, there are always chances of developing hypertension after the usage of Mithergin. So these kind of adverse effects are not there with the use of carbetocin. It is similar to oxytocin. Next slide. So the guidelines recognize the benefits of carbetocin for preventing uterine atony. So these are the recommendations, like WHO recommended of carbetocin. This SOGC Canada all these FIGO, Germany, FCOG, all the important bodies. So all they were like recognized the benefits of carbetocin, and they were asking them, all the clinicians, to use carbetocin. It is similar to the oxytocin in efficacy as well as in the. So the advantage over the oxytocin is that it is heat stable and it is long acting. So now my experience with carbetocin,
Yes, madam.
how it is more superior and safer choice in PPH management.
Since
See,
how long you have been using, madam, this
yeah, more than
Carbetocin?
1 year, I think
Okay.
we are
And you use
using.
IV or I route of
We
administration?
give, we usually in our hospital, we dilute it in 100 ml normal saline and
Okay.
we give IV.
19.
Yes, and we are very comfortable using. Until now, I have not experienced any adverse effect, adverse drug
Wonderful.
reaction, any allergic reaction with carbetocin yet. So it is the safest medicine. And my experience is that in those patients in whom we anticipate that this patient can develop postpartum hemorrhage, like a lady with twin pregnancy, or a lady with gestational diabetes with big baby polyhydramnios, or multigravida. So in those, before using anything, we'll ask our anesthetist to give carbetocin direct. So, and we observed that after giving carbetocin, the need of other uterotonic agents usually doesn't occur. So the carbetocin takes care, and it has got a long duration of action. I think till 4 hours. So patient once the initial 2 hours period post delivery is the most crucial period, right? And this carbetocin acts well for the first 4 to 6 hours. So that is the reason why the use of other uterotonic agents has drastically reduced in those cases in which we use carbetocin. Sometimes unexpectedly, as the first slide has shown, in those women who are at no risk and suddenly they start bleeding, right? In those women also we have used carbetocin and we got good results.
That's very wonderful and reassuring. Use that's
Yes,
exactly what people want, the experience of our doctors.
yes. Not only
Yes.
me, the other my fellow gynecologist consultants,
Wonderful. Wonderful.
even my anesthetists, everyone
Wonderful.
is like happy with carbetocin. The
And I
advantage is
mean,
that it is heat stable.
correct. And a single dose, maybe IV infusion is also not required in some of the cases. I mean, all these are,
So all these cases, I have told you
yes,
the
yes,
normal
yes.
delivery or in
Your
C.
experience you have already told us. And apart from the patient profile which you have described, there may be some other patient, maybe diabetics, maybe fibroids. Are they more prone to get PPH?
Of course, any anomaly of the uterus, right? If
Okay.
there is a difference in the shape of the uterus,
Acha.
so these in our heart, there is a pacemaker
Hmm.
which will help heart to contract. In uterus also there are pacemakers, right? So if the location of these pacemakers are changed, if the waves doesn't flow
Hmm.
properly, the contraction wave,
Contractions.
the uterus won't contract. So in case of
Correct.
unicornuate uterus, bicornuate
Okay.
uterus, or if there are fibroids,
They are
so
fibroids.
any pathology with the uterus, you have to anticipate postpartum hemorrhage.
Correct.
So in such conditions, it is difficult to do surgical maneuvers also.
Absolutely. Absolutely.
So that is why at the time we depend again on these uterotonic agents.
Correct. 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 I mean, that's a time when you can expect the worst and better use the best one available at that point of
Yes,
time.
yes,
Yes,
yes, sir.
correct.
Yes.
Actually, when would you prefer a carbetocin or oxytocin? You already said that in case of high risk patients, I will not take your time on this.
See, oxytocin, carbetocin, both are equally efficacious. The
Yes,
advantage is that, as we have already discussed, is it is heat stable because
correct,
of its long duration of action. If I
correct.
do a delivery in the night time, I want to go home and sleep well. I prefer carbetocin over oxytocin, right? Because I can't continuously call my assistant doctor.
Absolutely, absolutely.
So that's why this way carbetocin is superior to oxytocin.
And in periphery also it matters where there is less of medical help, less of nursing staff. A
Yes.
single dose, I mean, no, because there is power outages in big cities. Periphery to बात ही नहीं है. But these things can happen. Can we use carbetocin in case of retained placenta?
Yes, sir. Because again, in retained placenta, the problem comes again to the tone itself. When there are
Okay.
any retained bits
Yeah,
of
yeah, yeah.
placenta or membranes inside the uterus, Yes, of course, we'll try to remove them manually.
That's correct.
During
That's
this
correct.
process, again, uterus goes into atony and finally
Yeah,
we
yeah,
have
yeah.
to use carbetocin.
Fatigue may be possible in these cases.
Yes.
Uterine fatigue. Can you use carbetocin in RH negative mothers?
Yeah, yet now there are no studies which will prevent us
Correct.
using carbetocin in RH negative, but Mithergin is contraindicated.
Yes, yes, yes.
So for us, carbetocin is the best option to use
Correct.
in RH negative mothers.
And prevention of PPH in RH negative is ultimately important because we may
Yes,
not get blood
yes,
at the
sir.
time we require.
So there is no contraindication as
There's no
of now.
yeah.
There are no clinical studies which have
Correct.
asked us
Correct.
to avoid using. We can use carbetocin.
If a doctor uses carbetocin for prevention, can a doctor use carbetocin for prevention if oxytocin is used for
Yes,
labor
yes, sir.
induction?
Yes,
Yes.
even I've seen studies where they
Yes.
have used oxytocin for induction of labor and
Correct.
carbetocin for prevention of
Also,
PPH.
there's a short life, short
Yes.
half-life, and then the effect wouldn't
No
remain that
harm
long.
happened to the
Yes,
patient.
yes. In which cases you would prefer IV route or IM, or is there a place for IM route in therapy?
Sir,
Or
it
better use
is
IV?
like doctor's preference and how they
Yeah,
are
yeah,
used
yeah.
to use it.
I mean,
I
the anesthetist facilities available. I mean, all
yes.
those. Yes. But preference is given to IV route in those cases,
IV.
wherever there's facilities available.
IV
And
because if the patient has any discomfort, we can immediately stop the IV.
absolutely. And
And
madam, what is your take on a pre-filled syringe of carbetocin?
yes, in periphery, this prefilled syringes may be of use.
Yes, yes, yes,
Because
because
in this setup, we already put an intracap to the patient who is in labor.
correct,
We'll be
correct.
monitoring. So I prefer going with IV route rather than
Absolutely, absolutely. And you always want a faster onset of action in this case.
yes. Yes.
If a patient is not responding adequately with carbetocin, what other additional uterotonics you would use? I mean, everything is the answer, but then
There is always
there
a
are
chain, right? We
yes,
follow
yes,
an
yes,
algorithm.
yes,
Oxytocin, carbetocin, both are same. And
same,
I don't use oxytocin if the carbetocin is not working.
correct,
I
rightly
have
so.
to use other forms of uterotonics, maybe prostaglandin F2 alpha, carboprost, or
Correct.
mesoprost, or
Correct.
ergot alkaloids like Mithergin. Step by step manner.
Yes, yes. We have discussed this advantage of carbetocin, but I suppose misoprostol and carboprost should be given in caution to asthmatics
Yes, sir.
in the
Mesoprost, carboprost, we
prostaglandins,
can't give to the asthmatic patients, and methyl
asthmatics,
ergometrin, we can't give to hypertensive
hypertensive.
patients,
That's
RH negative pregnancies.
yes, yes. And,
So this is the advantage of carbetocin over the others.
and madam, how commonly you have seen oxytocin ADH related side effects?
AD?
ADH related, I mean retention of water with with oxytocin,
Sir, that happens in overdosage, right?
overdosage, excessive use.
It is always better to avoid more amount of like
Correct.
IV fluids to the patient, which can cause sodium
Yes,
toxicity.
yes.
So because both are equal, like oxytocin, carbetocin, the same happens.
Yes.
So it is always to
Better
give
than
IV fluids at the proper dosage. Carbetocin, etc.
I mean, you already
No,
answered this.
not required. We can use carbetocin as a first line agent
That's
only.
what I said. You already answered that. Adverse effect profile, how would you compare carbetocin with the oxytocin? You have not seen any side effect with carbetocin as yet. God bless, you should not see also. But
Yes, sir, because it is a stronger medicine, long acting. As you have said, the sodium intoxication and
yes.
this hyponatremia, it is one of the complications that we can expect with
Oxytocin.
carbetocin. So if we take care of that, it is one of the safest things that we can use.
This is last slide, madam. What is your one-liner on carbetocin?
Carbetocin is a lifesaver. It is a heat stable and long-acting medicine. So that's why my first line of agent for as a uterotonic, I prefer carbetocin, especially in those women in whom we anticipate PPH.
Correct.
So this is the take-home message I want to.
Thank you so much, madam, and thanks for joining. Despite your busy schedule, thank you very much. One interesting insight I got, use of antiplatelet drugs leading to PPH. I mean, I was completely unaware of this. Wonderful.
Sir, to get good results now, what we doctors want to give 100% positive result to the patient.
Absolutely.
So nowadays we see many people conceiving after 37, 38 years.
Yes, correct.
So these women, they have issues of hypertension. They have resistance in their uterine arteries.
That's
So
correct.
we are
Antiplatelets.
forced to use these ecosprints and all.
Correct.
With all these ladies, and we see more amount of IVF pregnancies, right?
Oh, yeah.
So IVF, they use heparin.
Yes, enoxaparin, heparin they will use. Yes.
So that's why these are clinically we are creating like
Correct.
coagulopathies.
But correct. Very well said, because the platelet will be less and the contraction may not happen, the clot
Yes,
formation. Yes.
yes, clot
Thank
forms.
you so much, madam. Thanks for your time. Thank you very much. And thank all the participants who took time from their schedule and attended this program. Thank you, marketing team Heathrow. Thank you, sales team for coordination. Last but not the least, thank you, IT team for your super support. Thank
Thank
you.
you, sir, for
Signing
giving
off.
me this
Thank you.
opportunity, and I am really happy. And the session went really very well. The
Well.
Q&A session is also really.
Yes.
I really
Thanks.
enjoyed the session. Thank you so much.
Thanks so much, madam. Thank you. Signing off. Wish you a very good evening. Thank you.
Thank you, sir.
You can sign off, madam. Yeah. Giridhar, I can log out.
Yes.